So coming to the clinical manifestations, acute leukemia, I'm sure you would have all come across children with acute leukemias, but the presentation is going to be very, very non-specific. Child could come to you with a low grade fever, 2 to 3 year old, so low grade fever, very, very irritable children. They will have bone pain, so they will just be crying. Irritable children, not allowing that particular bone to be touched. It can be very severe that the child is waking up at the night and complaining of the bone pain. That can be there. So malaise, not able to feed, anorexia will be there, losing weight, very, very fatigued child. So lot of children coming to us with very non-specific symptoms. Okay, so this can be there for weeks to months together. Okay, and once the disease has progressed to the bone marrow, like predominantly the bone marrow is affected with the blast, and then what happens, the bone marrow is replaced with the blast. So secondary bone marrow failure symptoms will come. So the child will have anemia. So because of that, the child will be very pale, fatigued, exercise intolerance. Your platelets have been replaced by blast, so bruising. So there can be spontaneous bruises, there can be bleeding, oral bleeding, mucosal bleeding, epistaxis can be there. And because of the replacement of neutrophils or replacement of WBCs, there will be fever. So this will happen once the disease has progressed. By this time, there will be complete blast. You will have, when you take the complete blood count, there will be 80,000, 1 lakh WBCs. So such high counts, at least more than 50,000. So this is regarding to the presentation. When you examine these children, definitely you will have this lymphoreticular system manifestations, like lymphadenopathy will be there, right? Hepatosplenomegaly will be there. Never forget external genitalia in a male. So testicular enlargement you have to see irrespective of the age. For CNS involvement, of course, if there are symptoms you can do. Otherwise, we are going to do the CNS, we are going to do the CSF tapping and look for the blasts. Respiratory distress can be there. One thing is because of severe anemia, or it can be because of the superior mediastinal syndrome. There is a mediastinal mass which is there and is compressing the SVC and the trachea, that is the airway. So clinically, I think most of this bone, of course, this is very, very important in examination. Bone tenderness. So you have to look for the sternal bone tenderness, which is very, very important. With marrow involvement, when you give a deep pressure to the sternal bone, there will be bone tenderness. Examine all the joints for any swelling and effusion. Okay, and for CNS involvement, of course, there will be, like, rarely only you will get signs of raised ICP. Okay, so examine the CNS completely, do a fundus examination, rule out papilledema, rule out any retinal hemorrhage. So this is very important. Okay, do a complete ocular examination also. Right. So coming to the B cell ALL. So this is the most common, isn't it? B-ALL or the B lymphoblastic leukemia is the most common immunophenotype of acute lymphoblastic leukemia. So the onset is somewhere between 1 to 10 years of age. And B cell ALL will have median WBC count is 33,000. Okay, not very high. So it is not like 70,000, 80,000. Even if you have, see here, this point, 75% of the patients will have counts less than 20,000. Even in sepsis, you will get, even in an overt bacterial infection, you will get 20,000, 25,000 WBCs. In leukemioid reactions, you can get such high WBC counts. So never ever, if you have high WBC counts, always do a peripheral smear from a good laboratory, from a good experienced pathologist. Okay, don't ever miss that. 75% will have thrombocytopenia, still 25% need not have thrombocytopenia. That is one thing you need to note. Okay, and only 30 to 40% will have hepatosplenomegaly, not everybody. Okay, so these percentages are very, very important. And only 5% will have CNS symptoms at presentation. For every child you are going to do CSF, you are going to do lumbar puncture, only 5% will have symptoms of CNS at presentation. And CNS leukemia, when are you going to diagnose? You do a CSF tapping and you find that more than 5 WBCs with blasts are present, you diagnose as CNS involvement, that is CNS leukemia. Testicular involvement is very, very rare and it is not evident at diagnosis also, but occult involvement is there. But testicular biopsy is not indicated at all. Okay. Coming to the diagnosis, you have done a complete blood count, you do a peripheral smear. Peripheral smear will tell you, okay, there is anemia, there is thrombocytopenia, blast will be there. So it has indicated bone marrow failure. Now you have to do a flow cytometry readily to identify what immunophenotype is there, what type of cells are there, everything. Your flow cytometry will be giving the clue. Next, you have to plan for the bone marrow aspiration and biopsy. A prompt bone marrow aspiration and biopsy has to be done. Referral at this point to a pediatric hemato-oncologist is very, very important, and subject that to both cytogenetics and molecular studies. So, bone marrow, mostly in these children, more than 25% of the cells, normal cells, will be replaced by lymphoblasts. Okay, and then you plan for a CSF examination, look for blasts. Okay, so staging LP. Now, when you want to do an LP, you can plan the staging LP. Okay, that is CNS involvement is there or not. You can plan this LP along with giving the first intrathecal chemo also. Many a time this is done. Okay, so once you have diagnosed based on the bone marrow, you can plan an intrathecal chemotherapy, and then you do a lumbar puncture, remove the CSF, give the intrathecal chemo and come off. Okay, so it is combined together.